Imagine you decide to just completely overhaul your home security.
Right, like sparing absolutely no expense.
Exactly. You spare no expense. You install biometric scanners on the doors, laser tripwires across the hallways, thermal imaging in the backyard.
Oh, wow, going all out.
Yeah, and heavy-duty reinforced deadbolts on literally every entry point, so you go to sleep feeling, completely impenetrable.
But I'm guessing there's a catch here.
There is a massive catch. There's a catastrophic engineering flaw hidden in the architecture of the system you just bought.
Okay, what is it?
Well, the sensors work perfectly. The tripwires detect every single movement. But the system is completely detached from the alarm siren.
Oh, man. So the wires were just simply never connected.
Right. The machinery is processing the breach, but the notification protocol is entirely non-existent.
That is a terrifying thought.
A burglar could pry open a window, walk up the stairs, stand right in your bedroom, and start packing up your valuables. The thermal imaging sees them, right?
Yeah, the motion detectors are tracking their every move.
But you are fast asleep because the house is dead silent. You wake up the next morning, look around, and genuinely believe everything is perfectly fine simply because you didn't hear a bell.
Because we rely so heavily on the alarm to tell us when we're in danger.
Exactly. Welcome to this deep dive. Today, we are pointing that exact analogy directly at you. Not your house, but your own biology.
We are examining an astonishingly dangerous gap in the human experience.
Yeah, we're unpacking this really profound disconnect between how medical conditions actually operate on a cellular level inside of us and how we as patients actually perceive them through our senses.
And that disconnect, it forces us to look at the broader landscape of how we handle medication safety as a whole.
Which is a mess, by the way.
It really is. It's why a massive portion of the population is walking around completely misunderstanding the very chemicals they ingest to stay alive.
So to help us navigate this, we are dealing with a really incredible source text today.
Yeah, it's an internal framework. It's essentially a foundational manifesto and an educational blueprint.
Produced by the editorial and medical research team at an independent medical information platform called iMedix.
Right, and the specific initiative they are launching in this document is titled The Silent Pressure, Unmasking the Experience of Hypertension.
And our mission for you, listening to this deep dive today, is to figure out why patients fundamentally misunderstand their own health.
We want to explore why the medical industry's standard way of communicating medication risks is just fundamentally broken.
Yeah, and how independent platforms are attempting to reconstruct that entire communication architecture from the ground up.
It's a huge undertaking. So let's unpack the very first prompt in the iMedix document.
Yeah, let's get into it. The editorial team anchors their entire educational philosophy on a single, seemingly simple question, right?
Exactly. They ask, what does hypertension feel like?
And the document insists that educators have to dig into the actual medical reasoning behind the issue rather than just relying on surface assumptions people make.
Because that prompt is actually a psychological trap. It's intentionally designed to force the researcher to confront a void.
A void? What do you mean?
Well, when we ask what something feels like, we expect a sensory catalog, right? Like if we ask what a broken bone feels like.
Oh, I can tell you that. Sharp, localized pain, swelling, heat. It's awful.
Right. You have immediate feedback. But when you ask what chronic hypertension feels like, the answer is an absolute void. It feels like nothing at all.
I actually want to push back on our own home security analogy for a second.
Okay, go for it.
The human body is usually a masterclass in alarm systems. I mean, we are evolutionarily wired to be super loud when things go wrong.
We definitely are. Pain is a very effective teacher.
Right. If I touch a hot stove, my somatic nervous system doesn't, wait for my brain to process the danger.
A reflex arc just yanks your hand back.
Exactly. While simultaneously flooding my consciousness with searing pain. Or if I get a viral infection, my immune system raises my core temperature.
You shiver, you sweat, your throat swells up.
Yeah, we rely on these undeniable visceral sirens to tell us we are sick. So why would the body, which is so incredibly good at signaling, like a tiny splinter in my finger,
Why would it completely fail to notify you that the pressure inside your entire cardiovascular system is reaching catastrophic levels?
Exactly. It makes no sense.
Well, to understand that, we actually have to look at the difference between the somatic nervous system, which handles the outside world, and the visceral nervous system, which monitors the internal organs.
Okay, break that down for me.
So your skin is packed with nociceptors. Those are pain receptors. Because a cut or a burn requires an immediate conscious behavioral change.
Right. You need to consciously pull your hand out of the fire.
But your blood vessels, particularly the endothelial lining inside your arteries, they just do not have those same pain receptors.
Wait, really? No pain receptors inside the arteries?
None. The evolutionary biological imperative never required you to consciously feel your blood pressure. Because historically, elevated blood pressure was a temporary, necessary survival mechanism. It was not a chronic disease state.
Ah, okay. You're talking about the fight or flight response.
Yes,
Yeah.
exactly. Imagine a predator is chasing you across the savannah.
Right, so my sympathetic nervous system kicks in.
It dumps a massive amount of epinephrine into your bloodstream. Your heart rate skyrockets.
And my blood vessels probably constrict, right?
Yes, they constrict to shunt blood away from your digestive organs and push it into your skeletal muscle.
So I can run faster.
Exactly. So your blood pressure spikes dramatically. And that high pressure is literally what keeps you alive in that moment.
Because it ensures oxygen is forcefully delivered to the tissues that need to sprint.
Right. But the body fully expects that spike to resolve within minutes, once the threat is gone.
So we do have specialized sensors to measure that pressure, though, right? I mean, I remember reading about baroreceptors in the neck.
We do have them, yes. We have baroreceptors located in the carotid arteries and the aortic arch.
And what do? Are they just measuring the flow?
They're basically stretch receptors. When blood pressure goes up, the vessel walls stretch, and these receptors fire signals to the brainstem.
Telling it to slow down.
Exactly, to slow the heart down and dilate the vessels. But here is the fatal flaw in the system.
The unplugged siren.
Right. Baroreceptors are highly adaptable. If your blood pressure stays elevated for days, weeks, and months.
Which happens constantly now due to, modern diet, chronic psychological stress?
Yeah, diet, stress, genetic factors,
Yeah.
sedentary lifestyle. If it stays high, the baroreceptors actually reset their baseline.
Are you serious? They just adapt to the new, higher pressure?
They adapt completely. They stop sending alarm signals to the brain. They simply say, I guess this is the new normal.
Wow. The alarm system physically unplugs itself.
It does. It adjusts to the trauma.
That is terrifying. So, because the baroreceptors reset and the interior of the blood vessels lack those nociceptors, a patient is walking around with dangerously high pressure pounding against the walls of their arteries 24 hours a day.
And their conscious brain receives zero distress signals.
But let's talk about the cognitive dissonance that creates, because people absolutely believe they can feel their blood pressure.
Oh, definitely. It's a very common misconception.
Yeah, like if you ask the average person on the street, they will give you a list of warning signs. They'll say, oh, I know my blood pressure's up because I have a splitting headache.
Or, I feel dizzy when my blood pressure acts up.
Right. So what's happening there?
Well, those assumptions are the exact real-world patient misunderstandings that the iMedix text is actively trying to dismantle.
So let's break down that headache myth, because it is incredibly pervasive, and honestly, it sounds medically dangerous.
It is very dangerous. People assume high blood pressure causes headaches, but they are confusing correlation with causation through the mechanism of stress.
Okay, let me see if I can map this out.
Yeah.
A person has a highly stressful day at work. They're anxious. Their neck muscles are super tight.
Right.
And that muscular tension and psychological stress trigger a tension headache.
Yes, that's step one.
But that same exact stress response, that sympathetic nervous system activation we just talked about, that also causes their blood vessels to constrict and their heart to pump harder, right?
Exactly. So they go to the pharmacy with a pounding headache. They sit down at one of those automated blood pressure kiosks.
Oh, yeah, the little machines by the pharmacy counter.
Right. And the machine reads, say, 150/95.
So they look at the number, they feel the headache, and their brain draws a false causal arrow.
Exactly. They think the 150/95 is physically producing the pain in their head.
When medically, the stress produced both conditions simultaneously and completely independently.
Precisely. And the vast majority of clinical studies show that mild to moderate hypertension does not cause headaches at all.
Wow.
In fact, some studies have paradoxically suggested that people with higher blood pressure actually have fewer headaches.
Wait, fewer? How does that work?
It has to do with the way elevated pressure interacts with certain pain-dampening pathways in the brain.
That is wild. So relying on a headache as a warning sign is just a complete illusion.
A total illusion.
But surely there are some symptoms, right? What happens if the pressure gets ridiculously high? Does the silent pressure ever actually make a noise?
It does, but only when it crosses a severe threshold into what we call a hypertensive crisis.
And what numbers are we talking about there?
Usually that's defined as a systolic reading over 180, or a diastolic over 120.
Okay, so incredibly high. What happens then?
At that extreme level, the sheer mechanical force of the blood can actually overcome the blood-brain barrier's autoregulation.
Oh, yikes.
Yeah, the brain actually swells slightly. It's a condition called hypertensive encephalopathy.
That sounds horrible.
That is when you get the severe, unyielding headache, visual disturbances, confusion, or nausea.
But waiting for a hypertensive crisis to tell you that you have high blood pressure.
It's like waiting for your house to burn down to its foundation to realize you left the stove on.
Exactly.
Yeah.
Because the damage has been happening quietly for years before that crisis hits.
Decades, sometimes.
Let's dig into what that silent damage actually looks like then, because if I don't feel it, why should I care?
That's the million-dollar question for patients.
Right. If the pressure is high but my body has adapted, what is actually breaking down in the background?
Think of your vascular system as a massive, really complex network of flexible plumbing.
Okay, plumbing. I can picture that.
Healthy arteries are lined with a single layer of delicate cells called the endothelium.
The endothelium. Got it.
It is perfectly smooth, almost like Teflon, which allows the blood to flow without any friction.
So nice and easy.
But when blood pressure is chronically elevated, the physical shear stress of the blood rushing against that lining actually creates microscopic tears.
Oh, wow. So the pressure is literally blasting the Teflon off the pipes.
That is exactly what's happening. And the body obviously tries to heal those micro tears
Oh.
by sending inflammatory cells to the site. But those microscopic scabs become catch points for low-density lipoproteins.
Oh, LDL cholesterol. The bad cholesterol.
Right. LDL cholesterol and calcium circulating in your blood. Over time, plaque builds up in those exact spots.
And that's where the plumbing gets clogged.
The arteries narrow, they stiffen, and they lose their flexibility entirely.
Which forces the heart to pump even harder to force blood through narrowed, rigid pipes.
Which then raises the blood pressure even more. It is a vicious, silent feedback loop.
And this leads to the end organ damage, doesn't it?
Absolutely. Think about your kidneys. They rely on incredibly delicate capillary networks to filter waste.
And your eyes, too, right?
Yes, the eyes rely on tiny vessels to supply the retina. If you are blasting those delicate networks with high pressure, day after day, year after year, they simply blow out.
So you end up with kidney failure or vision loss.
Or the plaque ruptures and causes a massive stroke or a heart attack.
Which is why routine screening is quite literally the only defense mechanism we have against this.
It is, because the only way people typically discover they have this condition is incidentally.
Right, like they go in for a completely unrelated issue.
Exactly. Maybe a twisted ankle or a physical for a new job, or they just go get a flu shot.
And the nurse wraps the, what's it called? The sphygmo.
That's a sphygmomanometer.
Right, the cuff. And they wrap it around your arm and catch the elevated numbers.
And the patient feels perfectly fine, but the numbers reveal the silent progression of the disease.
And that brings us to a massive psychological hurdle. I mean, put yourself in the shoes of that patient for a second.
It's a very disorienting place to be.
Seriously. You feel energetic, you sleep well, maybe you just played a full round of golf. You go in for a routine checkup, and the doctor looks at you gravely.
So you have a chronic, severe disease.
Yeah, your blood vessels are stiffening, you are at high risk for a stroke, and you need to take these pills every single day for the rest of your life.
It's a lot to process.
As a patient, your empirical lived experience completely contradicts the medical data.
Exactly.
How on earth do you accept a diagnosis when your own body is screaming that you are perfectly healthy?
It requires an enormous leap of faith. I mean, we are asking patients to override millions of years of evolutionary programming.
Programming that says pain equals sick, no pain equals healthy.
Exactly. We are demanding that they place absolute epistemic trust in a clinical measurement over their own sensory perception.
That's a huge ask.
It is. And when the medical establishment fails to adequately explain those invisible mechanisms we just discussed, the microtears, the baroreceptor adaptation, the patient simply cannot bridge that cognitive gap.
They just don't buy it.
They don't. So they take the medication for a week, they feel fine, they run out of pills, and they just don't bother to refill them.
Because why would you treat a disease you literally can't feel?
Exactly.
Especially when the treatment often makes you feel worse.
Oh, this is where the narrative really takes a dark turn for the patient.
Right. Let's say they actually trust the doctor. They take the prescribed blood pressure medication, but the medication itself introduces side effects.
Now we have a scenario where the disease is totally silent and painless. but the cure causes fatigue or dizziness or a dry cough.
You have suddenly introduced an artificial, highly visible symptom to treat an invisible problem.
And from a behavioral psychology standpoint, the patient makes a very simple, almost subconscious calculation.
Taking the pill makes me feel sick. Stopping the pill makes me feel healthy.
That's it. Which means if patients fundamentally misunderstand the nature of a silent condition, they are practically guaranteed to mishandle the medications prescribed to treat it.
Right. If we accept that patients are flying blind without symptoms, and we know they hate taking pills that introduce negative sensory feedback, how are they supposed to actually navigate the reality of the medication?
Usually they are forced to rely on the regulatory warning labels provided at the pharmacy.
And this is where the iMedix text really shifts its focus heavily to the treatment side.
It does. It emphasizes the need to discuss practical safety implications, the relevant regulatory or warning context, and how to map issues to similar drugs.
I want to aggressively challenge the premise that patients don't have enough information about their drugs, though.
Okay, let's do it.
If you go to a pharmacy right now and pick up a prescription for a common blood pressure medication, say lisinopril,
Sure, very common ACE inhibitor.
they staple a massive, endlessly folded piece of paper to the bag. It is like a CVS receipt of doom.
It really is. Printed in 6-point font.
Yes, it lists every single molecular interaction, every demographic warning, and literally every bizarre side effect ever reported.
Right.
The FDA or the EMA ensures that every possible piece of data is handed directly to the patient. So if that comprehensive regulatory context is already in the patient's hands, why does the iMedix text claim that people misunderstand medication risks? Isn't that label the ultimate map?
The label is a map, yes, but it is a map written in a language the patient doesn't speak.
Okay, fair.
It prioritizes landmarks the patient doesn't need, and it's designed primarily to protect the cartographer rather than guide the traveler.
Wow, okay, break that down.
You are conflating comprehensive data with comprehensible information. They are not the same thing at all.
I see.
The iMedix text specifically highlights the difference between regulatory context and practical safety implications.
So what exactly is the regulatory context doing if it's not actually trying to keep me safe?
Regulatory context is essentially a legal shield.
A shield for the manufacturer.
Exactly. When a pharmaceutical company runs a phase 3 clinical trial for a new drug, they might have, say, 10,000 participants taking the pill for a year.
Okay, that's a lot of data.
During that year, the company is legally required to record every single adverse health event that happens to those 10,000 people.
Regardless of whether the drug actually caused it.
Regardless, if a participant catches a cold, nasopharyngitis goes into the database.
Wait, seriously?
Yes. If a participant trips and sprains their wrist, musculoskeletal pain is recorded. If a participant happens to suffer a heart attack that was entirely due to their underlying disease, it is still recorded as an adverse event during the trial.
Wait. So when the FDA compiles that warning label, they are just dumping the raw, unfiltered trial data onto the page. They don't filter out the background noise.
The regulatory agencies require incredibly strict statistical reporting to ensure absolutely nothing is hidden.
Okay, I guess that makes sense from a transparency standpoint.
It does. So the label will say something like, headache occurred in 4% of patients.
Which sounds high if you're the one getting the headache.
But what the label often obscures in its dense, unreadable formatting is the background rate.
What do you mean by background rate?
In the placebo group, the people taking a literal sugar pill headaches might have occurred in 3.8% of patients.
Oh, so the drug itself barely moves the needle.
Exactly. The drug only caused an extra 0.2% of headaches. But human beings are notoriously bad at processing raw statistical probabilities without context.
Yeah, we really are.
When a patient unfolds that massive paper and sees headache, dizziness, fatigue, cardiac arrest, they don't see a statistical distribution.
No, they see a guaranteed menu of personal suffering.
Precisely. They assume every word on that list is going to happen to them.
That makes total sense. If I read that a drug might cause sudden cardiac death, even if the absolute risk is like 1 in 2 million, my brain elevates that to an imminent personal threat.
It's human nature. The legal armor designed to protect the manufacturer from liability ends up paralyzing the patient with fear.
So what does iMedix actually mean by translating this into practical safety implications? How does that differ?
Practical safety is the application of human context to raw data.
Give me an example.
Let's look at the blood pressure medication example again. If a patient is prescribed a beta blocker, the regulatory label will explicitly list fatigue as a prominent side effect.
Right. And the patient reads that and thinks, this pill is draining my energy, it's toxic, I need to stop taking it.
Exactly. But practical safety explains the mechanism. A beta blocker literally blocks the receptors in the heart from responding to adrenaline.
Okay, so it stops the heart from racing.
Yes, it lowers the heart's speed limit to protect the blood vessels from high pressure.
So when the patient tries to, run up a flight of stairs.
Their heart physically cannot accelerate the way it used to. And that mechanical limitation feels like fatigue.
Oh, wow.
Practical safety means telling the patient, listen, you might feel unusually tired when exerting yourself because the drug is doing exactly what it's supposed to do.
It is preventing your heart from racing.
Right. This isn't a toxic reaction. It's the physical proof that your invisible disease is being controlled. And the fatigue usually lessens as your body adapts to the new, healthier baseline.
That is brilliant. You take a terrifying side effect, explain the actual pharmacology behind it, and suddenly it transforms from a reason to quit the drug into actual proof that the invisible treatment is working.
It completely flips the narrative.
That is a massive paradigm shift, and the source text points out a specific methodology for doing this, which is comparing the issue with similar drugs or situations.
Yes, mapping the information.
Why is mapping new information to similar drugs such a crucial part of this translation layer?
Because it drastically reduces the cognitive load on the patient. Pharmacology is wildly complex.
Yeah, the names alone are impossible to pronounce.
If a doctor prescribes an ACE inhibitor and then switches the patient to an ARB, an angiotensin receptor blocker, the patient is dealing with a totally alien vocabulary.
They have no idea what that means.
But if a platform can map these drugs relationally, it changes everything.
Let's use a real example of that. Why would someone switch from an ACE inhibitor to an ARB in the first place, and how does the mapping actually help?
The classic example in medicine is the dry cough.
Oh, I've heard of this.
Yeah, about 10 to 20% of people who take ACE inhibitors, like lisinopril, develop a persistent, hacking, dry cough.
And the regulatory label probably just says cough.
It just says cough. It doesn't tell you why at all.
So what's the biological reason?
The ACE enzyme normally breaks down a peptide called bradykinin.
Okay.
When you inhibit that enzyme to lower your blood pressure, the bradykinin builds up, accumulates in the lungs, and irritates the nerve endings.
Causing a cough.
Exactly.
So the patient starts coughing, and they probably think they've developed asthma or lung cancer.
But in reality, it's just a harmless, albeit incredibly annoying, buildup of a peptide.
Right. Now, if the doctor says, okay, let's switch you to an ARB, like losartan, the patient might be terrified to take it.
Because they assume all blood pressure drugs will destroy their lungs.
Yeah, if the first one did this, the second one will too.
But an independent platform using the similar drugs framework can explain it clearly.
How so?
We can say, ARBs do the exact same job of lowering your blood pressure by acting on the same physiological system, but they bypass the ACE enzyme entirely.
Therefore, they do not cause the bradykinin buildup.
Exactly. Your cough will disappear, but your pressure will remain controlled.
That is so elegant. You are utilizing the brain's natural desire to categorize things.
You don't ask them to memorize the entire biochemical pathway.
No, you just say, it's like the old drug, but we remove the part that tickles your lungs.
Exactly. It makes it approachable.
Yeah. This really makes me realize the sheer scale of the structural failure we are dealing with. I mean, if you are listening to this and you've ever felt completely overwhelmed standing in a pharmacy aisle,
trying to parse drug interactions or side effects for a loved one.
Right, you need to understand that the confusion isn't a personal failing. You weren't bad at science. You were simply handed the raw, uncompiled code of a software program and asked to use it as a user interface.
And building that actual user interface is exactly what requires an architectural shift in how medical data is stored and presented.
Which leads us directly into the mechanics of the iMedix platform itself.
Let's get under the hood.
Yeah. The source text describes iMedix as an independent medical information platform built on a foundation of a comprehensive drug database seamlessly integrated with educational resources.
Right. And their stated goal is to explore treatment questions and foster broader medication safety discussions.
I want to know how this actually works, because you can't just build a spreadsheet of pills and call it a day. What does the architecture of understanding actually look like?
To do what iMedix is proposing, you have to build a highly complex relational database mapped to standardized medical ontologies.
Okay, big words. What does that mean?
You can't just list drugs alphabetically. You have to map the chemical structure, the mechanism of action, the pharmacokinetics, which is how the body metabolizes it, and the clinical outcomes.
So it's heavily interconnected.
Very. In medical informatics, they use terminologies like Rx norm to classify the drugs and SNOMCT to classify the clinical findings.
So it's essentially a massive web of interconnected nodes. Like the node for lisinopril is connected to the node for ACE inhibitor,
Right.
which is connected to the node for bradykinin accumulation, which then connects to the clinical node for dry cough.
Yes, exactly. And that allows the platform to perform queries that a human brain or a static paper label simply cannot process quickly enough.
Give me a scenario where that is useful.
Say a patient is taking a statin for their cholesterol, a calcium channel blocker for their silent hypertension, and they drink grapefruit juice for breakfast.
Oh, I've heard grapefruit juice messes with medications.
It really does. The static paper labels are useless in this scenario because there are too many variables.
But the database isn't.
Right. The relational database instantly flags that the grapefruit juice inhibits the CYP3A4 enzyme in the liver,
Which does what?
which prevents the metabolism of both of those drugs, leading to massive, potentially toxic blood levels of the medications.
Wow. It takes the bird's eye view that we just can't see on our own.
It's the only way to catch complex interactions.
But I want to zero in on the most important word in their mission statement, which is independent.
Yes, that is crucial.
Why is independence the absolute linchpin of this entire operation? Couldn't the massive pharmaceutical companies just build these relational databases themselves? I mean, they have infinitely more money than an independent startup.
They have the money, sure, but they fundamentally lack the structural objectivity.
Right, the bias issue.
We talked earlier about epistemic trust, how a patient has to genuinely trust the information to overcome the psychological barrier of taking a pill for a silent disease.
Especially a pill that makes them feel worse.
Right. In the medical information ecosystem, trust is routinely compromised by financial incentives.
That's putting it mildly.
Historically, a massive amount of patient education material has been produced, funded, or heavily influenced by drug manufacturers.
Right. The people whose fiduciary duty to their shareholders is to maximize the sales of their specific patented molecule.
Exactly. And while pharmaceutical companies are strictly regulated and legally barred from outright lying, they use highly sophisticated marketing techniques to shape the narrative.
How do they do that?
Their educational materials are always going to highlight the novel benefits of their expensive branded drug while softly minimizing the risks.
Or subtly discouraging the use of older, cheaper, generic alternatives that might actually be just as effective.
Precisely. They aren't going to foster a broader medication safety discussion. If that discussion leads the patient to conclude they don't actually need the company's product.
Or that a competitor's product has a cleaner safety profile.
Exactly. Furthermore, a pharmaceutical company's database is inherently siloed.
Meaning they don't share nicely with others.
Pfizer isn't going to build an interface that perfectly maps the synergistic interactions of their drug with a drug made by Merck unless legally forced to do so.
So an independent platform acts as an objective arbiter.
It sits above the fray. It has no financial stake in the formulary tiers, no kickbacks from pharmacy benefit managers, and no incentive to push a branded pill over a generic.
Its only mandate is clarity, safety, and translation.
Yes.
I want to extrapolate on this because it brings up a fascinating dynamic regarding the future of healthcare as a whole.
It really is a turning point.
The complexity of modern medicine is just growing exponentially. We are discovering new biological pathways, new genetic interactions, and new synthetic molecules every single day.
It's impossible for any one person to keep up.
Right. But the traditional model of healthcare relies on a 15-minute clinical encounter.
If you're lucky.
Exactly. You sit in a room, the doctor listens to your heart, diagnoses the silent pressure, writes a prescription, and gives you a 2-minute overview.
Take this. Call me if you feel dizzy.
Is it even mathematically possible for a human physician to serve as the primary educational resource for a patient anymore? Are platforms like iMedix going to effectively replace the doctor's educational role?
It is a controversial shift, but I believe it is inevitable.
Really?
Yes, the human physician will never be replaced for diagnostics, clinical intuition, surgical intervention, or the physical exam.
The art of medicine requires a human being.
Exactly. But the informatics of medicine, the day-to-day management of complex pharmacological data, the human brain cannot keep up.
It's just too much data,
A doctor simply does not have the 45 minutes required to explain the nuances of baroreceptor adaptation, ACE inhibitor pathways, and dietary enzyme interactions to every single patient on their schedule.
The math just doesn't work. So the doctor becomes the architect who diagnoses the structural flaw and draws up the blueprint.
Right.
But they can't be on the construction site every day. The independent platform becomes the site manager, providing the daily dynamic instruction manual for how to actually live in the house safely.
That is a perfect analogy.
Uh-huh.
But to truly be an effective site manager, the platform cannot just take a medical textbook and digitize it.
It requires a fundamental shift in the pedagogical approach.
Yes, it changes how we teach entirely.
Which brings us to the final section of the source text, which essentially demands that the team rewrite the rulebook on medical education entirely.
The instructions are very specific.
Incredibly strict, but in a totally counterintuitive way, they explicitly forbid traditional formatting.
Right. The text mandates, do not turn educational content into a generic drug monograph.
And do not follow a rigid, repeated structure. Instead, the focus must be on dynamic exploration, explicitly utilizing mediums like the official iMedix YouTube channel.
It's a huge departure from the norm.
I want to play devil's advocate here for a minute.
Okay, lay it on me.
I am a very organized person. I like predictability. When I look up a medication on a traditional medical website, a generic drug monograph is comfortable for me.
Because you know what to expect.
Right. I know exactly where to find the dosage. I scroll down to find the contraindications. I look for the half-life. Why on earth would iMedix ban a rigid structure? Doesn't abandoning predictability risk making the information chaotic and just harder to parse?
It seems counterintuitive until you realize that a predictable format does not equal deep comprehension.
How so?
The generic drug monograph is a transactional document. It is designed for acute data retrieval.
Give me an example of an acute situation.
If you have a severe bacterial infection, say strep throat, you are in pain, you have a fever, the disease is loud.
Right, the siren is blaring.
You just want to know, how many of these amoxicillin pills do I take, and when will my throat stop burning?
Just give me the facts so I can fix it.
Exactly. A rigid bullet point monograph works perfectly for that because your relationship with the drug is short, transactional, and purely symptom-driven.
It's an input-output scenario. I take the pill, the pain stops, I move on with my life.
But now, apply that exact same rigid bullet point structure to the silent pressure.
Right, hypertension.
Hypertension is not transactional. It is an intricate, lifelong negotiation with your vascular system.
That's a great way to put it.
A bullet point that says, take 10 milligrams daily to lower blood pressure, completely fails to address the psychological burden of taking a pill when you feel perfectly fine.
It completely ignores the emotional reality of the patient.
And a bullet point that says, side effect, dizziness, fails to explain the fluid dynamics of why standing up too fast causes a temporary drop in cranial blood flow while the medication adjusts your baseline.
You cannot encode a profound shift in personal identity into a generic monograph, because that's what we are really talking about, isn't it?
It really is an identity shift.
When you are diagnosed with a silent chronic illness, you have to transition your identity from healthy person to person managing a lifelong disease.
Exactly. And human beings do not change their identities based on bullet points.
We change our identities based on narratives. We need context, analogy, and dialogue.
Which is why the iMedix editorial team rejects the rigid monograph in favor of a dynamic YouTube channel. They are intentionally choosing narrative transportation over raw data transfer.
Because a video essay on a YouTube channel allows you to visually animate those micro tears in the endothelial lining we talked about.
It makes the invisible visible.
Right. It allows a host to modulate their tone, to express genuine empathy for the frustration of dealing with a dry cough, to validate the patient's skepticism.
It allows the educator to anticipate the psychological friction and address it in real time, much like we're doing right now.
They are basically returning to the oldest form of human knowledge transfer.
Or storytelling.
Exactly. Before the printing press, before the FDA, human beings transmitted critical survival information through storytelling and shared exploration around a fire.
And medical data is, quite literally, modern survival information.
But by stripping it of its narrative context and reducing it to a rigid, legally defensive spreadsheet, the medical establishment inadvertently alienated the very people it was trying to save.
They turned survival into a compliance checklist. iMedix is trying to rebuild the fire.
That is a beautiful way to phrase it, rebuilding the fire. And that brings us full circle.
It does.
Let's pull all of these really complex threads together and look at the tapestry we've woven during this deep dive. We started with the specific biological mystery of the silent pressure.
Right. What hypertension actually feels like, which is nothing.
We explored the evolutionary reasons why the human body fails to alert us to hypertension, diving into the incredibly adaptable nature of baroreceptors and the absolute lack of nociceptors inside our blood vessels.
We saw how that physiological silence creates a really dangerous vacuum of sensory feedback.
A vacuum that patients inevitably fill with false narratives.
Like mistakenly believing that stress-induced headaches are reliable warning signs of high blood pressure.
While the real microscopic damage quietly cascades toward catastrophic organ failure in the background.
Right. And from there, we examine the immense psychological friction of treating an invisible disease with medications that cause highly visible side effects.
We deconstructed the colossal failure of regulatory warning labels, exposing how those massive scrolls of trial data act as legal shields for manufacturers rather than practical maps for patients.
And finally, we explored the structural solution. The architecture of independent platforms like iMedix.
By combining rigorous relational drug databases with dynamic, narrative-driven educational resources, they serve as the ultimate translation layer.
They maintain the objectivity necessary for epistemic trust.
And they abandon the rigid generic drug monographs in favor of the contextual storytelling required to actually change patient behavior.
It is a monumental shift in how we handle medical knowledge.
Which leaves me with a final, slightly provocative thought I want you to carry with you after this deep dive ends.
I love these.
The entire philosophy we've discussed today is centered on empowerment. It is about ripping the complex, dense medical data out of the hands of the institutions and translating it perfectly into your hands.
Knowledge is power, as they say.
But empowerment always comes with a shadow.
The shadow of responsibility.
Precisely. For the last century, the doctor and the pharmacist were the absolute gatekeepers of medical knowledge. Because the language of medicine was so opaque, the burden of safety fell entirely on them.
If something went wrong, the patient could honestly say, I simply didn't know.
But if platforms like iMedix succeed in their mission, if the silent conditions are unmasked, if the databases perfectly map the drug interactions, if the YouTube channels flawlessly explain the pharmacology in plain English,
The veil of ignorance is totally lifted.
does this democratization of knowledge fundamentally shift the ultimate burden of responsibility?
That is a fascinating question.
In the future, when the translation layer is perfect and accessible on the phone right in your pocket, will the onus of medication safety fall less on the prescribing physician and heavily, undeniably, onto your own shoulders?
You're in charge of your own security system at that point.
It is a heavy question and something to deeply consider the next time you hold a prescription bottle and decide whether or not to swallow the pill. Thank you for joining us on this deep dive. Keep questioning the systems around you, keep unmasking the truth, and always stay curious.